Okay, good afternoon. My name is Emilio Madrigal, and I am in Manhattan, New York, with my co-resident Rifat Manan. Today, we are joined by Dr. Bill Faquin, who is the Director of Head and Neck Pathology at the Massachusetts General Hospital. And he's also the co-chair of the Milan system for reporting salivary gland cytology. We are broadcasting this lecture live on Facebook, Periscope, and on YouTube. And Dr. Faquin will be happy to take questions from our global audience at the end of the session. So thank you, Dr. Faquin, and thank you for your time. And so I'll go ahead and turn the screen over to you now.
Thank you, Emilio, for that introduction. It's a real pleasure to be here. I'm currently in Boston at Mass General Hospital and Harvard Medical School. And what I'd like to do over the next 45 minutes to an hour is discuss salivary gland fine needle aspiration, and most importantly, discuss the new Milan system for reporting salivary gland cytopathology, because I think it has the potential to have some very significant impacts on salivary gland FNA and patient management. So to start with, this shows a composite of 9 different images of tumors, just a few of the tumors that we can see in the salivary gland. The problem with salivary gland, both on surgical pathology and cytopathology, is that there's such a wide array of different tumors that we can encounter, including primary tumors, non-neoplastic lesions, as well as metastatic disease. And among all of these tumors, there is a lot of overlap. Many of the benign and low-grade cancers can show cytomorphologic and histologic overlap, so they can be difficult to distinguish. There's often overlap between many of the high-grade carcinomas that you can see in the salivary gland. So with that, I would say with all of these different kinds of tumors that we can encounter, as well as non-neoplastic lesions, what is the role for salivary gland fine needle aspiration? This is an image of a classical example of a fine needle aspiration of pleomorphic adenoma. And the good news is that salivary gland FNA, in the vast majority of cases, is able to make a definitive diagnosis of this tumor being benign and a pleomorphic adenoma. Of course, we recognize it by its very characteristic fibrous matrix material that can sometimes be cartilaginous, and the bland myoepithelial cells that are embedded within it. In a small subset of cases, however, you might see a pleomorphic adenoma that's very cellular, like the one here on the upper left, that doesn't have much of that characteristic matrix. Or you might see a pleomorphic adenoma such as the one in the lower right that has sebaceous metaplasia going on, or many other types of metaplasia. These two examples, fortunately, they're rare, but when you have cases of pleomorphic adenoma like this, we have a difficult time on cytology making the definitive diagnosis. And what I'm going to show you in a little while is that when we use the Milan system, cases such as this would be into a category of neoplasm of uncertain malignant potential. And we'll come back to that. Here's another example. This is salivary gland FNA of an adenoid cystic carcinoma. And when the adenoid cystic carcinoma looks like this would be a cribriform type of adenoid cystic carcinoma. It has that very characteristic cookie cutter-like sharp edges of matrix material that's bright pink. We call it metachromatic on this air-dried diff-quick stain preparation. And we have these basaloid cells surrounding these very, very well-defined matrix globules. This pattern is very characteristic of adenoid cystic carcinoma. And if you had this pattern and it's in the proper clinical scenario, the patient perhaps has nerve symptoms, or clinically we recognize it as malignant, you can make a diagnosis of adenoid cystic carcinoma. However, There are also cases of adenoid cystic carcinoma, such as the solid subtype shown here in an FNA, which doesn't have the characteristic matrix, and it may be very difficult and sometimes almost impossible to definitively make a diagnosis of adenoid cystic carcinoma on FNA on cytomorphology alone. We'll come back at the end of this talk to mention some of the ancillary markers that can help us out and help us to go the extra mile to make a more accurate FNA diagnosis. But if you have a case like this, it's probably going to end up in that uncertain malignant potential category that I'll tell you about in the Milan system. Now, this is a table that I put together, which I think is very helpful to me, and hopefully it's helpful to you as well. And what I've done is I've listed many of the different lesions that you can encounter in the salivary gland. And oftentimes what I'll do when I get a salivary gland FNA is that the initial look at the FNA under low and intermediate magnifications will tell me a lot. There's some lesions where usually I can make a very specific diagnosis. For example, pleomorphic adenoma, Warthin tumor, a reactive lymph node. Oftentimes we can make a very specific diagnosis of these on FNA. Other times, other lesions such as adenoid cystic carcinoma, it depends upon the subtype you're dealing with. Is it cribriform? Is it tubular? Is it the solid type that I showed you a photograph of? Similarly, for low-grade mucoep, it depends on the quality of the sample. Do you just get mucin, or do you actually get a sample that has a lot of epithelial cells, epidermoid, mucus cells, intermediate cells in a background of mucin? So it depends. Some of these tumors in this middle column we can make a definitive diagnosis on, and sometimes we can't. There are other lesions where I'm almost certain from the get-go that I'm probably going to have to make a descriptive diagnosis. That includes some of the low-grade tumors, such as polymorphous low-grade adenocarcinoma, basal cell adenocarcinoma. There are many different variants of that. The membranous type, oftentimes we can diagnose, but most of the other types of basal cell adenocarcinoma, we have to put into a category of basaloid neoplasm. So I'm going to talk more about these different items as we move forward and discuss the Milan system. But again, one of the take-home messages would be that our ability to make a definitive diagnosis depends upon the quality of the sample as well as the nature of the tumor. And many of these tumors can have various subtypes, and it'll depend upon the subtype that you're dealing with. Just a few basic facts about salivary gland tumors. In general, they're uncommon, being about 0.4 to over 13 per 100,000 people. More often they occur in older adults, more often in women, and a majority of them occur in the parotid gland. Overall, approximately 75% of salivary gland tumors are benign, and that's mostly because of the contribution from the many tumors that we see in the parotid gland. Most of you are hopefully already familiar with this fact, but it's very important for us as cytologists as well as for the treating clinicians to be aware that the risk of malignancy of a salivary gland tumor is inversely proportional to the size of the gland. And by that I mean that if you have a tumor in the parotid gland, there's only about a 20% chance that it's going to be malignant. If you're dealing with a tumor in the submandibular gland, the risk of malignancy goes up closer to 50%. And if you're dealing with a tumor in one of the minor salivary glands, such as in the oral cavity, the risk of malignancy can go up to 80 to 90%. So I think it's important to keep that in mind, the site of the tumor, when we're coming up with our differential diagnosis and trying to classify based on cytomorphology. I'd also like to mention something about the location of the tumors. You can see the parotid gland here, and you can see the branches of the facial nerve running between the superficial and deep lobes. One thing to keep in mind is that oftentimes tumors of the superficial parotid gland will occur in the preauricular area. Many of the tumors of the parotid gland will occur in the tail of the parotid gland, here at the angle of the jaw. And it's not uncommon, if you're actually doing the FNA, for the clinician to send the patient to you and say, this patient has a lymph node in the upper part of their neck, when in fact you do the FNA and it's a pleomorphic adenoma, and you realize you're dealing with a tumor that's located here in the tail of the parotid. Also, occasionally we'll get patients who have salivary gland tumors, generally from the parotid gland, located in the cheek. And some of these will represent tumors of the accessory parotid tissue, which can lie anywhere along Stenson's duct overlying the masseter muscle. And the tumors that you would get in this location would be exactly the same ones that you could get in the salivary gland, parotid gland proper. So what about the effectiveness of salivary gland FNA? Overall, it's got a pretty good accuracy. Part of the reason for the high accuracy of salivary gland FNA is that a majority of the salivary gland neoplasms come from the parotid gland, where many of them are pleomorphic adenomas and Warthin's tumor, and also many of the malignant ones are metastatic cancer to intraparotid and periparotid lymph nodes. And we do a great job on FNA at making a definitive classification of these tumors. Overall, the sensitivity of salivary gland FNA for cytomorphology alone is between 86 and 100%. So generally it's very good. And I say cytomorphology alone because there's also a role for frozen section in certain cases, and it's been shown that the combination of a prior FNA diagnosis plus a frozen section diagnosis leads to even greater accuracy in making a definitive classification. So back to accuracy of salivary gland FNA, we do a very good job of distinguishing the benign and low-grade neoplasms from high-grade malignant tumors. And in just a moment, you'll see why that's very important in terms of driving clinical management. So we do a really good job of distinguishing these two groups. We don't do as good a job with identifying or classifying a specific lesion. And by that, I mean, is it epimyoepithelial Is it myoepithelial As I mentioned earlier, is it basal cell adenocarcinoma? So some lesions we don't do a great job with, and other things like pleomorphic adenoma and Warthin tumor, we do a great job. And that's the reason that we have such a broad range here for identifying a specific lesion. So what is the rationale for salivary gland FNA? It can be very helpful for guiding the clinical management and developing a pre-op strategy. So if you do a salivary gland FNA and you call it non-neoplastic, perhaps the patient can avoid surgery and will just get clinical follow-up. If you're able to classify the tumor as a benign tumor, such as pleomorphic adenoma, or as a low-grade carcinoma, then in that case, if it's in this group, even if you don't put a specific label on it, the patient's likely going to go for a limited surgical resection with negative margins. If you're dealing with metastatic disease to a parotid lymph node, the patient has a history, for example, of skin cancer of the scalp, and you do an FNA of a parotid mass and it's metastatic squamous cell carcinoma to a lymph node, then that patient can be triaged for lymph node dissection. If you do an FNA of a lymph node, maybe you'll be able to tell them it's a reactive node, in which case the patient could be followed, or using ancillary studies such as flow cytometry, you could tell the clinician it's a lymphoma. You may even be able to subclassify the lymphoma, and in those cases, the patient would go on for a hem-onc referral. So in contrast to this group of benign tumor low-grade carcinoma, if you make a diagnosis of a high-grade primary carcinoma of the salivary gland, the patient's likely going to have some sort of radical surgical resection that may involve nerve sacrifice if it's in the parotid gland, and likely in many cases it will involve some form of lymph node dissection. And so I think you can see here how salivary gland FNA can help to triage patients, that can help guide the clinical management and develop the pre-op strategy. So with that as a little bit of background, now let me pose a question. Why do we need a new reporting system for salivary gland cytology? And I would say, well, for one thing, we don't even really have a uniform reporting system right now. So that's one hurdle to overcome. So there's a lot of current reporting confusion out there. There's a lot of diversity in diagnostic categories that different institutions throughout the world, and even throughout the United States, and even throughout one state in the United States, different diagnostic categories that folks are using. Some folks don't even use cytology categories. They just give a descriptive report. At other institutions, surgical pathology terms are used rather than cytology terms. And basically the way things are right now for salivary gland FNA, there's really no direct correlation of the cytologic diagnosis with a risk of malignancy or with a clinical management algorithm. So I think what we're facing is that there is a general agreement on the need for a defined set of diagnostic categories for salivary gland FNA. This will allow for a clarity of communication between the cytologist and the treating clinician, and this communication will involve an implicit cancer risk for each cytologic diagnosis. It will also allow for exchange of data across institutions. And so what has happened is that through the support of the American Society of Cytopathology and the International Academy of Cytopathology, a group of us came together. We met at the European Cytology Congress in 2015 in Milan, and decided that we needed a reporting system, and we're calling it the Milan system for reporting salivary gland cytopathology because of that first face-to-face meeting in Milan, Italy. So the Milan system is sponsored, as I mentioned, by the ASC and the IAC. We have over 40 participants as co-authors from 15 different countries working on the development of this reporting system. And these participants include not only many expert cytopathologists, but also expert surgical pathologists and expert clinicians, head and neck clinicians. The goal of the Milan system is to produce a practical classification system that is user-friendly and internationally accepted. The system, as I've already alluded to, will be evidence-based. It will correlate risk of malignancy with diagnostic categories with a management algorithm. There will be a print atlas available. It's published by Springer. Sometime in late 2017 is when we anticipate the publication of this atlas. And there will also be a web-based atlas available with many, many different images representing the different diagnostic categories of the Milan system. And that will be available electronically through the American Society of Cytopathology. So the 40-plus members from 15 different countries are listed here. There are going to be 9 different chapters to the print atlas that include an overview or introduction, and then the various categories, diagnostic categories. There'll also be a separate chapter on ancillary studies, immunohistochemistry and molecular studies that can be applied to FNA of salivary glands, and then a separate chapter on clinical management. So, what are the diagnostic categories of the Milan system for reporting salivary gland cytopathology? They're listed here. The first one is non-diagnostic. The second is non-neoplastic. The third is Atypia of undetermined significance, and you'll note that we borrowed this term from the Bethesda system for thyroid cytopathology because most of us are very familiar with this term and with this category. The fourth category is neoplastic, and it's divided into two subcategories: benign neoplastic and neoplastic uncertain malignant potential. The fifth category is a standard category that we're used to using in cytology, suspicious for malignancy, and then the sixth category is malignant. So what I'm going to do is take you through each of these categories and just give you some of the basics of what the category means and some examples of entities that would be placed into each of these diagnostic categories. Before I do that, let me show you right now the draft of the risks of malignancy and management algorithm associated with the six different diagnostic categories. We are currently looking at the literature. There are more manuscripts being published as we speak and written as we speak, which will contribute to refining the risk of malignancy. I think you can see that for the non-diagnostic category, there is a significant risk of malignancy, and that's because, as you might expect, many of these fine needle aspirates that are termed non-diagnostic are simply sampling errors that are missing an underlying cancer. And the clinical management for these would be very careful clinical and radiologic correlation and repeat FNA under ultrasound guidance. And then if that doesn't work, the potential for either core biopsy, open biopsy, or surgical resection would be considered. For the non-neoplastic category, the risk of malignancy can range from 0 to 10%. Again, some of these non-neoplastic lesions may represent a reactive condition, and simply the FNA did not properly sample the underlying neoplasm. So again, for this category, very careful clinical follow-up and radiologic correlation is needed, and in a subset of cases where the clinical and radiologic findings are concerning, surgical resection may be needed. For this atypical category, we're still working on the risk of malignancy. We expect some material to come out in the near future. But the management would be repeat FNA or surgery. For the neoplastic category under benign, generally these are going to have conservative surgery or clinical follow-up. And for this uncertain malignant potential category, you can see that the risks of malignancy are going up now gradually. This has a risk of malignancy in the 20 to 40% range, and generally most of these patients will have some kind of conservative surgery. Most of the malignancies in this category are going to be low-grade carcinomas. Moving up to the suspicious for malignancy category, the risk of malignancy goes up to 60 to 70%. Most of these patients will have surgery, and correlation with clinical and radiologic features will help to inform the clinician as to whether we think this may or may not be an aggressive tumor, and it can also be correlated with frozen section. For the malignant category, it's very important to designate the tumor as low-grade versus high-grade because that impacts the management. And as you see over here, surgery is indicated for most of these patients, and again, correlation with low-grade versus high-grade to determine the extent of surgery. And these are associated with risk of malignancy going up into the 90% or higher spectrum. So as I alluded to earlier in this talk, the risk of malignancy for some of these categories will depend upon the nature of the specimen and the salivary gland site. So if you're in the parotid gland versus submandibular versus the palate, the risk of malignancy could vary somewhat. So let me take you through each of these diagnostic categories and just tell you a little bit about them. Let's start with the non-diagnostic category. In this category, we're dealing with FNAs where there's an insufficient quantitative and or qualitative cellular material present to make a cytologic diagnosis. We would hope that 10% would be the target maximum rate for non-diagnostic salivary gland FNAs. The FNAs in this category would include aspirates that contain benign salivary gland elements only, without any other indication for why there would be a salivary gland mass. And also within this category of non-diagnostic, it would include cases of cyst contents only, and in particular, non-mucinous cyst contents. And we'll talk about the mucinous cyst contents in a few minutes because that's a special case. Here's an example of a salivary gland FNA where in this image, all you can see are basically normal, benign salivary gland elements. We have small lobular groups of acinar cells arranged in a pretty much normal pattern, interconnected by ductal epithelial cells. So this is really just benign, normal salivary gland epithelium. And there was some discussion among our co-authors on the Milan system whether this should be called benign or rather non-neoplastic versus non-diagnostic. But it was felt that many of these cases, especially if there's a discrete salivary gland mass clinically and radiologically, should be interpreted as non-diagnostic with a note or comment that this sample may not be representative of the lesion and that further workup is probably indicated. So again, that's shown here. For aspirates containing only normal salivary gland elements, a cautionary note is recommended. And the note could read something like this: clinical and radiologic correlations are recommended to ensure that the aspirate is representative of the lesion. The findings in this aspirate do not explain the presence of a salivary gland mass. So I mentioned non-mucinous cyst contents. If there is no epithelial component present and you simply have an aspirate that contains histiocytes and debris in the background, maybe some inflammatory cells, so that is cyst contents only and no mucin, non-diagnostic is the place to put it. And there's a range of different lesions that this could represent. Again, we don't have an epithelial component, so this could be a pseudocyst, it could be a ductal cyst, or it could actually be a cystic neoplasm. And again, the quality of the sample, we're just not getting perhaps an adequate sample to classify it further. Let's move now to the non-neoplastic category. So these specimens are lacking evidence of a definitive neoplastic process. Many of these salivary gland FNAs are going to be inflammatory processes. They may show metaplastic changes and or reactive changes. And so these aspirates include acute, chronic, and granulomatous sialadenitis. They may also include sialadenosis. A lot of the cases in this category could be reactive lymph nodes, and flow cytometry or some kind of ancillary immunophenotyping would be needed to confirm that it's a reactive lymph node when you're going to place it into the non-neoplastic category. Clinical radiologic correlation is really essential in this category to ensure that the specimen is representative of the lesion and that we simply haven't sampled something overlying a neoplasm and not sampled an underlying neoplasm. So we have to be very careful about that. And as I mentioned earlier, a subset of these non-neoplastic lesions may eventually need to be surgically excised to exclude a poorly sampled neoplasm, especially if there are clinical or radiologic indications that there may be something else going on besides one of these inflammatory processes or just a reactive lymph node. So an example, a common example in the non-neoplastic category, especially when you're dealing with a salivary gland nodule of the parotid, would be a reactive lymph node. And this is an example of an FNA of a reactive lymph node where you typically have a mixed population of lymphocytes in the background, a majority of which are small, mature-appearing lymphocytes. You'll have some tingible body macrophages present here, and you may see germinal center fragments present in your sample. These are all features that we associate with reactive lymphoid conditions. Reactive lymph nodes are very common in all age groups, or in a broad age range in the region of the parotid. Both periparotid and intraparotid lymph nodes are not uncommonly reactive, and that's because you can have variable degrees of infections and things that travel down from the face, the skin, the head and neck to the region of the parotid lymph nodes. However, with that said, although we would be inclined to say reactive lymph node, immunophenotyping combined with cytomorphology is the key to diagnosing and subtyping a reactive condition versus a lymphoma. So we always want to include that immunophenotyping, and generally most folks will use flow cytometry on a part of their FNA sample to confirm that a lymph node is reactive or benign. The other point of caution is for negative lymph nodes. Generally what I like to do is to put a note suggesting repeat fine needle aspiration or tissue biopsy if the lymphadenopathy persists. And as we all know, that's because in a subset of cases, you can have lymph node aspirates which will have a negative or benign flow cytometry. For example, a Hodgkin lymphoma, or for example, a B-cell rich T-cell lymphoma, or some large cell B-cell lymphomas can give a negative flow cytometry. And again, that's why we use cytomorphology. We still have to look at the cells under the microscope, and if we see atypical features, we need to mention those despite the fact that there could be an associated negative flow cytometry. Another example of a non-neoplastic salivary gland FNA would be chronic sialodenitis. In general, aspirates of chronic sialodenitis give hypocellular aspirates, so not many cells are there. What we'll often see are these small, angulated, cohesive basaloid groups, as we see here in the middle of this image. These are because you get atrophy of the salivary gland, you lose the acinar cells, and you may or may not get some slight proliferation of the ductal epithelium. And usually you'll aspirate small basaloid ductal groups, and you'll have a degree of chronic inflammation scattered in the background. Sometimes aspirates of chronic inflammation can be difficult to distinguish from a basaloid neoplasm, and those kinds of cases may end up in our atypical or AUS category. But generally, if it's a hypocellular aspirate, they're just a few small, tightly cohesive basaloid groups with background chronic inflammation. In the appropriate clinical setting, and we like to have as much clinical information as we can get, we can recognize it as chronic sialodenitis. Granulomatous sialodenitis occurs in a subset of patients. One of the more common findings of granulomatous sialodenitis is sarcoidosis, but as we would expect, we also have to exclude infection. Hopefully the clinician will have sent cultures, but we can also do stains for organisms. We can do a GMS and an AFB to exclude the presence of organisms. And also keep in mind that in rare cases, granulomatous inflammation can be associated with certain neoplasms. Sialolithiasis is another condition in our non-neoplastic category. So if we have an FNA and it shows fragments of a stone, such as we have here, and maybe some inflammation in the background, we can classify this as sialolithiasis and non-neoplastic. The next diagnostic category of the Milan system that I want to mention is the AUS category, Atypia of Undetermined Significance. So this is a category where we cannot entirely exclude a neoplasm. This would be a heterogeneous category. A majority of the samples, FNA samples that would fall into this AUS category will be reactive atypia or possibly poorly sampled neoplasms. You'll also have specimens that are compromised either due to air drying or obscuring blood clot. And our objective here is that this category would be used rarely. We would hope that less than 10% of salivary gland FNAs would fall into the AUS category. And most of the cases in the AUS category will require close clinical and radiologic correlation, as well as some form of tissue biopsy or resection. Now, I mentioned this earlier, and that is mucinous cyst contents only. So we don't have any epithelial cells to say what exactly the type of cyst we're dealing with. We know it's some type of mucinous cyst because of all of this mucin in the background. This is an air-dried Diffquick preparation, stain preparation. But if you have mucin like this in the background of a cyst on a salivary gland FNA, you cannot exclude the possibility of a low-grade mucoepidermoid carcinoma. And for that reason, this sort of aspirate should be placed into an atypical category to warn the clinicians we can't exclude a low-grade mucoepidermoid carcinoma. Another example of an entity in the AUS category would be an aspirate such as this, where we have very bland, sort of benign-looking oncocytes. Maybe there are only a few of them. This is a liquid-based preparation. If this were admixed with benign salivary gland elements, your differential diagnosis could be between an oncocytosis, which is a very common process, especially in older individuals, versus a true neoplasm, such as an oncocytoma or some oncocytic variant of another type of neoplasm. So if you're not sure if it's a neoplasm or not, you would place it into this AUS category. Here's one more example of a lesion that might fall into the AUS category. Is this reactive? Is this a reactive process? Is it a chronic sialolithiasis, or is it actually a basaloid neoplasm? This is an example of a very rare entity, sclerosing polycystic adenosis, but it's just to illustrate that this particular aspirate shows these tight clusters of basaloid cells. It's actually more cellular than I would expect for chronic sialolithiasis, and it raises the differential of a basaloid neoplasm, except there's a lot of apocrine snouting here, and that looks more like maybe a metaplastic or reactive process. So it's really not clear from this aspirate, am I dealing with some kind of reactive process, or is it a true neoplasm? And so this is a sort of lesion where you, or aspirate, where you might put it into the AUS category. And again, it's going to be open to a little bit of subjective interpretation of where you want to place that FNA into which category in the Milan system. Moving on to the neoplastic or neoplasm category, this category will be used a lot in the Milan classification system. And as I mentioned earlier, there are two subcategories, the benign neoplasm and the salivary gland neoplasm of uncertain malignant potential. The benign neoplasm category is reserved for clear-cut benign neoplasms. Classical examples of things like pleomorphic adenoma, Warthin tumor, lymphoma. In contrast, the salivary gland neoplasm of uncertain malignant potential subcategory, this is a category, it's diagnostic of a neoplasm. However, a diagnosis of a specific entity cannot be made. And in addition, a malignant neoplasm cannot be entirely excluded. So it's different from the benign neoplasm category. We expect the benign neoplasm category to have a very low risk of malignancy if strict criteria are adhered to for diagnosing these classical pleomorphic adenomas and Warthin's tumors, etc. In contrast, here we're going to have variations of neoplasms where we cannot exclude a malignant neoplasm, and this subcategory is associated with a much increased risk of malignancy over the benign subgroup. So an example of a salivary gland aspirate in the benign, neoplastic benign category is shown here. It's a classic Warthin tumor. We have oncocytes, as we see here, uniform pattern of cells with large round nuclei, a prominent nucleolus, very well-defined cell borders, and oncocytic cytoplasm in a background of dirty cystic debris and scattered chronic inflammation. Here's another example of a classic pleomorphic adenoma that would be placed into the neoplastic benign category. The matrix-rich types of pleomorphic adenoma are definitely the easiest ones to recognize on FNA, and here we have two examples. Here on the left, you can see just abundant myxoid matrix material, this fibrillar appearance with a few scattered, very bland myoeps embedded within it. Here we have an alcohol-fixed pap-stained example of a classic pleomorphic adenoma. Again, this cotton candy-like fibrillar matrix with frayed edges and very bland myoepithelial cells embedded within it. So these are two very easy pleomorphic adenomas that we could definitely call neoplastic benign. Now, what about this second subgroup of neoplastic, the uncertain malignant potential? Here are two examples of pleomorphic adenomas that would fall into that category. And these are two examples where we have either atypia, focal atypia, such as we have on the right-hand side, or metaplastic changes, such as in this image on the left-hand side. This is squamous metaplasia. Again, it's you know, if you've seen enough pleomorphic adenomas with metaplastic changes, you may say, okay, it's probably a pleomorphic adenoma with metaplastic changes, but these look epidermoid. Am I sure it's not a mucoepidermoid carcinoma? On this side, yeah, it looks like it's probably a myoepithelial-rich pleomorphic adenoma, but I'm just not sure. This is a bizarre tumor cell here. Can I be certain that it's not some kind of malignancy? So both of these examples would be placed into this uncertain malignant potential category. Here's another example. This turned out to be myoepithelioma. It's a pure population of myoepithelial cells. There's some pleomorphism here, variation in cell size and nuclear size. And this is an example where if I'm not comfortable that this is a definitively benign tumor, if I can't exclude a malignant tumor, I'm going to place it into the uncertain malignant potential category. This is a category that is one of the most difficult in salivary gland cytology, and that's the basaloid neoplasm category. So you do an aspirate and you get groups of basaloid cells like we have here, and the differential diagnosis includes basal cell adenoma, basal cell adenocarcinoma, a cellular pleomorphic adenoma with basaloid features, and even adenoid cystic carcinoma, which we know contains basaloid cells. And unless we have material for ancillary studies, we oftentimes will not be able to distinguish between these different entities in the differential diagnosis. And this is the kind of aspirate that would fall into this neoplastic of uncertain malignant potential category, and we would describe it as a basaloid neoplasm with a differential, and the patient would likely go to surgery, and they would have a conservative surgery in most cases with negative margins. Moving on to the next category, suspicious for malignancy. Aspirates in this category are going to be highly suggestive of malignancy, but not definitive. Oftentimes, the salivary gland aspirates in this suspicious for malignancy category are going to represent high-grade carcinomas with limited sample, sampling or some other limitations. And just one example, if I have an aspirate from a patient clinically, they have nerve symptoms, it's thought to be malignant. Here's my aspirate, it's an air-dry diff-quick preparation. This really looks like the pattern of adenoid cystic carcinoma. However, there's a lot of smearing and plus the air drying artifact. It's hard for me to be 100% certain it's adenoid cystic, and if I don't have material for ancillary studies, I may decide to put this into the suspicious for malignancy category. Now moving to the malignant category in the Milan system. Obviously, these are for aspirates which are diagnostic of malignancy. It's very important to subclassify these aspirates into specific subtypes when you can, and especially into grades of carcinoma, low grade versus high grade. And as I pointed out near the beginning of this talk, the grading, low grade versus high grade, is very, very important for helping to guide the clinical management and develop that pre-op strategy that you're going to follow. Other malignancies, such as lymphomas, sarcomas, and metastatic disease, are also included in this malignant category and should be specifically designated. And I'll just show you a few examples that would fall into the malignant category. Here on the left, we have an aspirate of a clearly malignant tumor. These cells are large. They have very large nuclei that are pleomorphic with prominent nucleoli. There's some background debris that turns out to be necrotic debris. This is an example of a salivary duct carcinoma. At the least, you could call this malignant and high grade, and that's what would be enough to drive the surgical management. If you had material for ancillary studies, of course, like a cell block, you could look for androgen receptor positivity, HER2/neu positivity, p53 positivity to help clinch the diagnosis and give a specific histologic type to this tumor. Here on the right, again, we have an aspirate that's clearly malignant, and it's high grade, and that would be enough to help drive the clinical management. However, you'd want to do ancillary studies in order to subclassify this particular undifferentiated carcinoma. Here are two images of an adenoid cystic carcinoma, again of the cribriform subtype, which is the type that we most readily would be able to diagnose on FNA. And in the appropriate clinical scenario with an FNA that looks like this and plus or minus ancillary studies, you would be able to classify this as malignant adenoid cystic carcinoma. Here's an example of a malignant FNA of a salivary gland tumor that we were able to classify as a low-grade mucoepidermoid carcinoma. Mucoeps are a problem. They're a common cause of a false negative diagnosis, but this particular aspirate of a low-grade mucoep is one where we can definitively say it's malignant, it's mucoep. It's a great example. I wish they were all like this. We have not only the epidermoid cells, but the admixed goblet-type mucinous cells here in a background with mucin. Here's an example of an FNA of a parotid gland lymph node, and we have this dispersed population of cells with necrosis. It looks malignant. And if you did ancillary studies, you could show that these are lymphocytes and that they're a clonal population of B cells, and you could make a diagnosis of a high-grade B-cell lymphoma. So I've gone through the different diagnostic categories in the Milan system, and what I'd like to do is just spend the last few minutes mentioning some of the ancillary studies that we can use. So basically, improvements in immunocytochemistry, immunohistochemistry, and molecular testing will make the Milan system and salivary gland FNA in general more effective. And it's really critical that the FNA specimen include adequate material for ancillary studies in difficult cases. And so by that, I think it's an important take-home message we can only go so far on cytomorphology alone. Fortunately, cytomorphology does get us pretty far when we're dealing with things like Wharton tumor and pleomorphic adenoma. But when we start dealing with some of the other less common tumors and low-grade carcinomas, we really can only go so far with cytomorphology. And if you really want to make your FNA as effective and accurate as possible, you're going to need to make sure that you get material, generally in the form of a cell block, so that you can do some of these ancillary marker studies. What are some of the ancillary studies that we can do? Well, you can do immunocytochemistry on liquid-based preps and smears, although many labs, including ours, prefer to do immunohistochemistry on cell block material. And that's because our labs are used to dealing with formalin-fixed paraffin-embedded material as you have in a cell block, and also the controls that we have for immunochemistry go with those when you're doing the stains on the cell block. On the molecular level, you can do FISH analysis, you could do RT-PCR, and for molecular studies, our particular institution uses next-generation sequencing with a panel that looks for many different mutations as well as many different fusion genes. So, with regard to molecular markers and salivary gland tumors, we've actually come a long way in the last 5 to 10 years. We now have 7 different tumors in the salivary gland that are associated with either a mutation or a gene rearrangement. These include mammary analog secretory carcinoma, pleomorphic adenoma and carcinoma XPA, clear cell carcinoma, mucoepidermoid carcinoma, cribriform adenocarcinoma of minor salivary gland, adenoid cystic carcinoma, and basal cell adenoma. And just very, very briefly, I'm going to show you a few examples of these in selected salivary gland tumors. So with pleomorphic adenoma, as I mentioned earlier, we do a great job on cytology of diagnosing pleomorphic adenoma, and most cases will be diagnosed in the Milan system as neoplastic benign. There will be a small subset, generally less than 10%, where we can have diagnostic problems due to variants of pleomorphic adenoma. And these include variants that are very cellular and lack matrix, variants that may have adenoid cystic-like areas or atypia, or that may have some form of metaplasia. With regard to pleomorphic adenoma, as well as most of the matrix-producing tumors, immunohistochemistry generally is not extremely effective because all of the matrix-producing tumors stain with markers for ductal and myoepithelial cells. However, with pleomorphic adenoma, over half of cases are known to be associated with rearrangements involving the PLAG1 gene. And there is an antibody available, which is less specific than the molecular testing, but the antibody can be useful to give you some objective material or information, but molecular testing would be even better if you have that. This is an example of immunohistochemistry for PLAG1. It's a nice image of the nuclear staining of PLAG1. It was contributed by Dr. Jeff Crane at Brigham and Women's Hospital, who's done a lot of research on salivary gland cytology and histology. And over 94% of pleomorphic adenomas, greater than the number that actually have the PLAG1 gene rearrangement, overexpress PLAG1 and can be identified using this antibody. Keep in mind, though, that just because you might have PLAG1 positivity, either on the molecular or immunohistochemical level, it does not exclude the possibility of a pleomorphic of a carcinoma X pleomorphic adenoma, because when the tumor becomes malignant, it will also carry along with it the PLAG1 gene rearrangement. What about adenoid cystic carcinoma? Most cases will be diagnosed in the Milan system either as neoplastic of uncertain malignant potential or depending upon the quality of the sample and the subtype of adenoid cystic carcinoma, it may fall into the suspicious for malignancy or even malignant category. There are a couple of good immunohistochemical stains that we can use to help us with adenoid cystic carcinomas. Most cases of adenoid cystic carcinoma are strongly and diffusely positive for CD117, also known as KIT. And the other immunohistochemical marker that's very effective is MYB, MYB, which even works better on alcohol-fixed specimens than it does on formalin-fixed specimens, but it can be used on either, and it's a nuclear stain. And the combination of both strong diffuse staining with MYB as well as CD117 is very strong support for an adenoid cystic carcinoma. However, the ultimate help would be molecular testing, such as this FISH analysis here for the MYB oncogene rearrangement. And the FISH images that I'm showing were contributed by Dr. Garcia at the Mayo Clinic, and he's an expert in using FISH to look for molecular changes in some of these salivary gland tumors. Basal cell adenoma and adenocarcinoma, I've already mentioned this is one of the most difficult areas of salivary gland cytology. Most of these cases in the Milan system would be diagnosed as neoplastic, uncertain malignant potential. Here's an example of an FNA of basal cell adenocarcinoma, which is cytologically indistinguishable from adenoma. And some of the work from several different groups, including that by Dr. Crane and Dr. Joe over at Brigham and Women's Hospital, have shown that a majority of basal cell adenomas exhibit mutations in the beta-catenin gene, and a subset of basal cell adenocarcinomas also have these. And this is an image from their paper in AJSP showing one of these basal cell adenomas and the nuclear staining with beta-catenin. And I've actually used this immunohistochemical marker several times in the last few months here at MGH and found it very helpful for giving me something objective to confirm the diagnosis of a basal cell adenoma. We all are familiar with or have heard about mammary analog secretory carcinoma. In the Milan system, if you only have cytomorphology, it's probably going to fall into this neoplastic uncertain malignant potential category. However, if you can do ancillary studies, you may actually make the definitive diagnosis on FNA. Cytologically, aspirates look like this. They kind of resemble actinic cell carcinoma. However, they lack zymogen granules in the cytoplasm, and they have a lot of vacuolization. There is a very good immunohistochemical profile that's very, very helpful for making a more definitive diagnosis of MASC on FNA, and that includes positivity with GCDFP, S100 mammoglobin, and GATA3 would also be positive. And for difficult cases, you can certainly do the molecular testing for a definitive diagnosis of MASC in the salivary gland. This shows the nice FISH analysis. At our institution, we use next generation sequencing to demonstrate the ETV6 gene rearrangement. Actinic cell carcinoma is one that we can do a pretty good job of on FNA if you have material for ancillary studies. Most cases are diagnosed either as neoplastic uncertain malignant potential, suspicious for malignancy, or if you have material for ancillary studies, you can sometimes get all the way to malignant. And that's because there are two immunohistochemical markers that can be very helpful for making the diagnosis of actinic cell carcinoma. Those are DOG1, shown here on the left, which is strong diffuse membranous staining, cytoplasmic and membranous staining, and SOX10 here on the right, which should show strong diffuse nuclear staining. And together, these are very, very good for diagnosing actinic cell carcinoma. And the last example that I'm going to show you is our Mucoepidermoid carcinoma. Depending upon the sample that you get, as well as the grade of Mucoepidermoid carcinoma, the diagnostic category could range anywhere from AUS to SUMP to malignant. And here's an example of an FNA of a low-grade mucoep. We have one group of very bland-looking epidermoid cells and a lot of background mucin. Immunohistochemistry is generally not very effective for mucoepidermoid carcinomas. We expect the epidermoid cells to be p63 positive, but there's no specific immunoprofile. However, work by Dr. Sitala as well as other groups have shown, and we've known this for some time, that a majority of mucoepidermoid carcinomas do have rearrangements involving mech mammal, and either by FISH analysis as shown here on the right or by next generation sequencing, you can detect this rearrangement and make a definitive diagnosis of mucoepidermoid carcinoma. I've used this molecular analysis in several cases in both FNA as well as small biopsies, and it can prove very, very useful. But again, you need to make sure that you get material to do these ancillary studies. Otherwise, you're going to limit how far you can go with your salivary gland FNA diagnosis. So just to summarize, salivary gland cytology presents many diagnostic challenges. The Milan system for reporting salivary gland cytopathology will help to produce a uniform diagnostic structure. It will provide improved communication between the treating clinician and the cytologist, and it will improve patient care overall. The availability of immunohistochemistry and molecular markers can also greatly improve the accuracy of salivary gland FNA, but again, be sure for those difficult cases that you get the material you need in order to apply ancillary tests. So to summarize, we look forward to the implementation of the Milan system, and I hope that you will also find it useful for improving the FNA diagnosis and reporting of salivary gland lesions, and I thank you very much for your attention.
Excellent. Thank you so much, Dr. Faquin, for that excellent introduction and overview of the Milan system. So we have a couple of questions here. I'm going to read the first one. Here's from one of our, someone on YouTube. His name is Frido Bruel. He's from the Institute of Pathology at the University of Bern in Switzerland. And he just wants to know if you have any distinctive cytologic features for squamous metaplasia.
Distinctive cytologic features for squamous metaplasia. That's actually a little bit difficult to answer because it really depends on the nature of the sample and the nature of the lesion. Squamous metaplasia, it can occur in such a wide range of entities in the salivary gland, from non-neoplastic conditions such as chronic silanitis. You can get squamous metaplastic changes of the ductal epithelium. For those, I would say the hypocellularity, the small size of the groups can kind of suggest that you might just be dealing with squamous metaplasia. More commonly, we'll see it in a pleomorphic adenoma, and squamous metaplasia is the most common metaplastic change in pleomorphic adenoma. And in particular, if you see the presence of keratin pearls, and no features of marked atypia, such as with squamous cell carcinoma, but keratin pearls and very bland squamous metaplasia is actually not an uncommon scenario in a small subset of pleomorphic adenomas that are basically mimicking skin adnexal differentiation. And so when I see that combination, it's a lot easier to recognize it as squamous metaplasia. Unfortunately, I will say, there are no immunohistochemical markers that help, and depending upon the context and the rest of the sample, it may not be possible to put a definitive label on it. And I would definitely say that the patient's going to have to be followed very carefully, clinically and radiologically, to exclude the possibility that instead of squamous metaplasia, you're not dealing with epidermoid cells of mucoepidermoid carcinoma. And that's one of the other things I would look for, make sure there's no mucin in the background.
Okay, thank you very much. We have another question. Rifat has a question here from...
Yeah, we have a question from Dr. Charanjit Singh from Florida Hospital in Orlando. So he says that unlike gynecologic cytology and to some extent thyroid cytology, salivary lesions are a group of diverse lesions. So he believes that benign versus malignant and then low versus high grade may would have been suffice. And he is wondering that how risks of malignancy were determined for these classes from such diverse group of lesions. Thank you.
Thank you. That's a very good question, and I somewhat agree with the statement that he made about one of the important things is if we can just say it's non-neoplastic, or that it's a low-grade or benign neoplasm versus a high-grade carcinoma. Those are the most important things for guiding the clinical management. However, we can do better than that. And in fact, you know, if you have an aspirate of a salivary gland tumor, a majority of those are pleomorphic adenomas. And if you can tell the clinician, this is a pleomorphic adenoma, and usually we can, or this is a Wharton tumor, the patient may actually be someone who's not a good surgical risk, and they may want to follow the patient clinically and not send them to surgery. And so I think that's where, you know, it can be important to put a specific label on it to sort of reassure the surgeon. The other thing is that I feel like, and I'm not alone on this, that really going forward, we need a uniform reporting system. And the things that we mentioned about non-neoplastic, high-grade, low-grade are built into the system, but we also have the option, when possible, to go the extra mile of putting a specific label on some of these. And with regard to the ancillary studies that I mentioned, nowadays with immunohistochemistry and molecular testing, we actually can go the extra mile and make a definitive diagnosis on many of these tumors. And sometimes by being able to say, this is definitively adenoid cystic carcinoma versus uncertain malignant potential, there could actually be a difference in management there, because if they know it's adenoid cystic, you know, we've shown the MIB rearrangement by molecular testing, the clinicians may do a more extensive surgery with possible sacrifice of facial nerve because of the neurotropism involved. So overall, I think the Milan system kind of addresses both ways of thinking about this. You go as far as you can, but I agree, as long as you can put it into those general categories of non-neoplastic, low-grade, high-grade, you are going to very much help the clinician. The other thing is that by the clinician reading your report, we're all going to be using the same reporting system. The clinician can read your report and look at the diagnostic category and say, oh yes, that's associated with this sort of risk of malignancy. We got these risks of malignancy by carefully reviewing the literature and looking at meta-analyses that are available. And I will tell you that there is additional research that is in the pipeline that will be coming out that is helping us even further to refine the risk of malignancy. And then we also envision that going forward, there will be a lot more research that will help us to refine the risk of malignancy even further.
Okay, thank you very much. So that's going to be it for the questions. So thank you again, Dr. Faquin, for taking the time to speak with us today and give us this awesome overview of the Milan system. We really appreciate it, and we're looking forward to the publication of the atlas. So thank you very much for your time.
Thank you very much.
Okay.
Thank you.
Take care. Have a good evening.
Thank you, Dr. Faquin. Thanks a lot.
Thank you.
All right. Take care. Bye-bye.